Parkinson's disease is a chronic and progressive neurological disorder affecting dopaminergic neurons in the brain. The pathological processes of Parkinson's disease result in less dopamine being produced and stored in the brain. This disrupts many neural processes that rely on dopamine neurotransmission. Importantly, this includes movement and motor functioning. In a healthy brain, dopamine and acetylcholine exist in a balance with each other. In a person suffering from Parkinson's disease, there is a deficit of dopamine, and because of that, a relative excess of acetylcholine. This deficit and resulting imbalance produces the main symptoms of Parkinson's disease: resting tremor, rigidity, slowness of movement, called bradykinesia, and postural instability. Patients with Parkinson's also suffer from a wide range of non-motor symptoms, but this is outside of the scope of this talk. Today, we'll discuss the most commonly used medications available from a community pharmacy in Australia. There are a few rules that apply to all of them. So all Antiparkinsonian medications can cause nausea. To minimize this, the treatment should be started with a very low dose. We increase the dose slowly to the desirable effect. Nausea can also be reduced if the drugs are taken with food. However, the efficacy of levodopa can be significantly reduced by co-administration with food. In the initial stages of the disease, the effect of food will not be significant enough to negatively impact treatment. But in patients with later stages of Parkinson's disease, we can advise to take levodopa at least 30 to 60 minutes before a meal or an hour after a meal. In patients where food is found to be significantly affecting levodopa treatment, a trial with a protein redistribution diet can be helpful. This diet helps to manage fluctuations related to the effect of food intake on levodopa absorption by adjusting the diet so that the majority of protein intake is given at the end of the day. If nausea is still a problem, domperidone is our drug of choice. However, international guidelines warn against regular use of domperidone for longer than 1 week. This is because it's implicated in prolonging the QT interval and therefore puts patients at risk of life-threatening arrhythmias, especially when combined with other medications that also prolong the QT interval. Medications that have anti-dopaminergic activity must be avoided in Parkinson's disease. This includes chlorperazine, promethazine, metoclopramide, and antipsychotic medications. All dopaminergic medications can cause psychosis. If treatment of psychosis is required, the drugs of choice are quetiapine and clozapine. This is because they're less likely to worsen Parkinson's symptoms, because of their relatively lower antagonistic effect at dopaminergic receptors. One of the most important things to remember about anti-Parkinsonian treatment is to not stop therapy abruptly. Sudden withdrawal from dopaminergic medications can lead to symptoms resembling neuroleptic malignant syndrome. This is sometimes also called Parkinsonian hyperpyrexia syndrome. The main symptoms of neuroleptic malignant syndrome are fever, rhabdomyolysis, and muscle rigidity. Sudden withdrawal can also lead to acute akinesia, where a person develops a severe inability to move that can last for days. These syndromes are rare, but they're potentially fatal, and they can start developing as early as 18 hours after a missed dose, up to 7 days after sudden cessation of treatment. As our patients suffering from Parkinson's disease are often older patients with multiple comorbidities, it's important to keep this in mind. These patients may undergo surgical procedures or require unexpected hospital admissions. We should educate our patients and their relatives on the importance of letting healthcare workers know that they require these medications on time without interruptions to therapy. For example, the patient may be advised to take their medications with them to the hospital in case their prescribed medications are not readily available from pharmacy, or discuss with the doctor other options, such as a patch or parenteral treatment if oral intake will be interrupted for some time. The problem with Parkinson's disease is that we can't cure it. Levodopa works brilliantly to treat symptoms in the initial disease stages. It's the most logical first-choice treatment as it works to replace the dopaminergic deficit responsible for symptoms. But we don't know enough about it yet to recommend it as an initial treatment to everyone. Some research has shown that metabolites of levodopa may produce free radicals in the brain that can be toxic to dopaminergic neurons. However, some studies show the opposite, claiming that levodopa has neuroprotective properties. What we do know is that a patient's responsiveness to treatment with levodopa or other therapies may be limited to a certain time period. Half of patients will develop disabling motor dyskinesias and fluctuations after 5 to 10 years of medication treatment. Currently, evidence cannot confirm if these outcomes are related to the natural progression of the disease or if they may be influenced by levodopa therapy. This is an important discussion to have with our patients. There is still a degree of uncertainty if levodopa treatment may affect disease progression. This can influence their decision on when they want to commence levodopa therapy. When to start treatment with levodopa also depends on the patient's symptom severity, cognitive status, comorbidities, and life expectancy. Most commonly, our older patients over 70 years old and patients with cognitive impairment will be started on levodopa early to improve their quality of life. Younger and cognitively non-impaired patients may be better candidates for other anti-Parkinsonian medications. The initial treatment should be discussed with the patient, who has been informed of the risks and the benefits of each medication choice. The main medications that we see today are the MAO-B inhibitors, amantadine, dopamine agonists, levodopa, and anticholinergic medications. In Australia, the drugs of choice are typically levodopa and dopamine agonists. Some terminology to be familiar with is when the drugs are working well to treat the symptoms, we call it on time, and when the drugs stop working, it's called off time. Let's also quickly have a brief recap on how dopamine is metabolized. Dopamine cannot cross the blood-brain barrier. This means that if your patient takes dopamine orally or parenterally, it will not get to the brain where we need it. The prodrug of dopamine is levodopa. Levodopa is able to cross the blood-brain barrier. When levodopa is taken orally, it's absorbed into the bloodstream from the small intestine, but unfortunately some of each dose will get lost during this process. Once absorbed, levodopa can be metabolized by various enzymes. In the body, levodopa is degraded by COMT, or cattle column methyltransferase, MAO-B, monoamine oxidase enzymes, or it can be converted to dopamine by dopa-decarboxylase. These peripheral metabolic pathways will all inactivate levodopa before it can even enter the central nervous system. Therefore, they significantly reduce the therapeutic efficacy of levodopa. Once levodopa passes through the blood-brain barrier into the brain, it must be metabolized into its active form, dopamine, by the dopa-decarboxylase enzyme. However, before this occurs, it may again be degraded by our COMT or our MAO-B enzymes. To minimize the premature degradation of levodopa and to maximize the amount of active dopamine we achieve from each dose, we now always administer levodopa with enzyme inhibitors. Levodopa is always administered with a dopa-decarboxylase inhibitor, such as benserazide or carbidopa. We may also add a COMT inhibitor to therapy, entacapone. All three together exist as a drug called Stalevo, or its generic substitutes. In addition to these enzymes blocking degradation of levodopa, increasing the chances that a larger amount of levodopa will reach the brain, they also reduce adverse effects. The conversion of levodopa to dopamine in the peripheral tissues is responsible for our most common adverse effect, nausea and vomiting. Our enzyme inhibitors prevent levodopa being metabolized into dopamine peripherally and therefore improve the tolerability of treatment. COMT inhibitors, or entacapone, have no benefit in the early management of Parkinson's disease. Entacapone can be used for management of motor fluctuations associated with levodopa in the later stages of the disease. Entacapone increases the duration of motor improvement on time, but it can also increase levodopa-induced dyskinesias and gastrointestinal adverse effects. Now let's move on to our dopamine agonists. We rarely see ergo derivatives, so things like bromocriptine or cabergoline, prescribed for patients with Parkinson's disease. The recommended and most commonly prescribed representatives of the dopamine agonist class are pramipexole and rotigotine. Dopamine agonists mimic dopamine in the brain, and they act on dopamine receptors, but they're not quite dopamine, and therefore they're not an exact fit into our dopamine receptors. Therefore, they're not as effective as levodopa, especially at the later stages of Parkinson's disease. Pramipexole comes in a tablet form as either immediate release or an extended release formulation. An immediate release dosage form is used 3 times a day, and the extended release tablet is taken once a day, typically before bed. The total daily dose is the same for both preparations, so it's very easy to convert from an immediate release to an extended release tablet if needed. Only one transdermal formulation of a dopamine agonist is available in Australia, butigotine. It's a once-daily patch. The patch is a very good alternative for patients who can't take medications orally due to swallowing difficulties or during periods when the patient may be nil by mouth. Therapeutic guidelines have a table instructing clinicians how to convert oral levodopa or pramipexole to butigotine patches. Amantadine and rasagiline can also be used in early stages of Parkinson's disease, according to growing evidence to support this approach. In Australia, they're not recommended as a first-choice treatment by the therapeutic guidelines yet, but they are approved by the PBS for the use of Parkinson's disease without any restrictions. Amantadine is a strange drug. It's an antiviral medication, but it also increases the release of dopamine in the brain and reduces its reuptake. So more dopamine is in the brain for longer. It is an effective treatment for early stages of Parkinson's disease. However, the effects seem to wear off after about 3 to 6 months of use. Rasagiline and selegiline are irreversible inhibitors of the MAO-B enzyme. Safinamide is a newer addition and it's a reversible MAO-B inhibitor. MAO-B inhibitors prevent degradation of dopamine in the brain, and they preserve levodopa in the periphery and in the brain. Therefore, it can be especially helpful when it's used together with levodopa. Doses of selegiline higher than 10 milligrams a day should not be used in patients with Parkinson's disease. This can lead to a non-selective MAO inhibition and cause hypertensive crisis. In the advanced stages of disease, patients may be offered other treatment options. There are a few devices available now. For example, a continuous levodopa-carbidopa intestinal gel infusion. This drug is delivered by a pump right into the gastrojejunostomy. Another alternative is a continuous subcutaneous apomorphine infusion, delivered by a pump as well. There is also a surgical treatment, deep brain stimulation. In the US, we see other drug forms for delivery of levodopa, such as inhaled levodopa, and one of the newest drugs approved by the FDA is istradefylline, an adenosine receptor antagonist. Apparently, it's been used in Japan for years, but the FDA has just approved istradefylline when given in addition to levodopa for the treatment of wearing off symptoms.